Hello and good afternoon, everyone. I am Sheetal Mattu Kaushik from BMJ Marketing Team, and I'm delighted to welcome you all to the BMJ's first webinar of the BMJ India Webinar Series 2022 on Ischemic Heart Disease. BMJ is a global healthcare knowledge provider with a vision for creating a healthier world. We share knowledge and expertise to improve healthcare outcomes. I would now like to welcome Dr. Simi Kaul, who's our senior clinical editor at BMJ and has more than 15 years of rich experience in the publishing industry. Over to you, Simi.
Thank you, Sheetal, and thank you all for signing in for today's webinar. We welcome you all from the bottom of our hearts. BMJ is delighted to announce the BMJ India Webinar Series 2022 for clinicians across India. This series brings to you the latest evidence-based clinical updates, practical tips from expert speakers every month. It is specially designed to help you improve patient outcomes in your day-to-day practice. We would be discussing new topics every month with eminent speakers, and therefore requesting everyone who all are logged in right now to watch out for this space. Next slide, please, Sheetal. We would like to welcome Tata 1mg as the title sponsor for BMJ India webinar series. Before we proceed, few announcements. You can increase your screen size to view the video in the full screen mode. You can ask your questions while the session is going on by typing in your question in the chat box provided, and we will make sure that your questions are answered once we are done with the session, with the limited time we have in our hands. You can also answer the poll questions, which will be running shortly, by choosing the best answer whenever the question flashes onto your screen. Once we finish with the webinar, you can download the certificate through the link which will be provided to you on the screen. Do remember to follow us on LinkedIn and Facebook pages. Our ID is BMJ India. To register for the next webinar, upcoming webinar, which is scheduled for 24th February 2022. Shortly, we'll be giving more details on this. Participants who all have enrolled right now will be receiving Tata 1mg discount coupon for patients, which can be used for the patients. This will you will receive once BMJ will share the details by email. Next slide, please. We'll be running the question poll. So there will be 3 questions which we'll be asking. I'll read out the scenario for you, and you can choose the best answer and submit when the questions are flashed onto your screen. So we will now begin with our first question. I'll read out the question for you. So Mr. Singh, he is a 55-year-old male, non-smoker, 178 centimeters tall, weighing 68 kg, and has a total HDL cholesterol ratio of 4, blood pressure 176/84, and his HbA1c is 5.4 mg per deciliter, millimole per deciliter. Mr. Kumar, he is 55 years old male, 178 centimeters tall, weighing 85 kg, and has a total HDL cholesterol ratio of 5. His blood pressure is 146/78. HbA1c is 5.6. His father has a angioplasty with a stent at the age of 55. The question is, who has the higher cardiovascular risk probability for a future CV event? So there would be 4 options which are reflected right now on your screen. Please choose the best answer and submit. And your time starts now. You have 15 seconds to submit your answer. We are about to finish the time. Yes, can we have results, please? Interesting. I have to check by going to another sheet. Okay, can we have the next question, please? Second question, which of the following leads to the maximum benefit in reducing mortality in a patient of ST elevation MI? Is it the first, aspirin, second, clopidogrel, third, primary angioplasty, fourth, reducing time of reperfusion from 6 hours to 1 hour? And your time starts now. You have 15 seconds. Can we have results, please, now? Moving on to our next question, and this is the final one. Decision to start statin for the prevention of IHD in an individual is decided by option 1, is it absolute risk reduction? Option 2, relative risk reduction. Option 3, only if LDL cholesterol is higher than 160 mg per deciliter. Your time starts now, and you have 15 seconds. Results, please. Thank you so much, and let us begin. Thank you everyone for participating in the poll. And now let us start with our first clinical update. Our speaker today is Dr. Ambuj Roy. He's the Professor of Cardiology, Professor in charge, Skill, E-Learning and Telemedicine Center at All India Institute of Medical Sciences, New Delhi. Over to you, Dr. Ambuj.
Thank you, Simi. Can I be allowed slide sharing rights?
Yeah, sure.
And it's a privilege to be talking here on the first BMJ clinical webinar series. And thank you for choosing for me to speak on this rather important topic of ischemic heart disease, which we all know is the leading cause of mortality among Indians and also world over. So during the next half an hour or so, can you see my slides? Is it visible?
Yes, sir, it is visible.
Yeah, thank you. So, over the next half an hour or so, we would just like to sensitize. It's impossible to, completely cover this topic in a webinar, but I'd like to sensitize the early career, mid-career physicians on identifying risks and reducing them in patients, in individuals, so that they do not suffer from ischemic heart disease. I have no conflict of interest to report. Just a brief on the lingo. These words are very intermittent, changed, used between one another, whether it's CAD, which is coronary artery disease, coronary heart disease, ischemic heart disease. They essentially mean the same thing, and this is often used interchangeably. When you talk of vascular disease beyond heart, then we use the two terms atherosclerotic cardiovascular disease, which means vascular disease of like brain vessels, which gives rise to stroke, or disease of peripheral arteries, which can give rise to gangrene and claudication. So these are all atherosclerotic vascular diseases. So these are the broad learning objectives for today, which I have defined for this half an hour talk. So one is to understand whether Indians are more susceptible to ischemic heart disease. What are the things that put one at a risk for ischemic heart disease? How, when an individual sits across your table in your clinic, how you could assess whether what are his risks for ischemic heart disease? And once you do that, how do you risk mitigate? How do you reduce the risk of having ischemic heart disease in an individual who doesn't have the disease? And how do you reduce the chance of a recurrent cardiovascular event in those who already have disease? And all physicians must have a perspective of public health, and we'll briefly see how we could reduce the societal burden of ischemic heart disease or cardiovascular disease in general. So just this you must have all seen, read in your pathology classes. You know, the pathophysiology of ischemic heart disease is long drawn. It's not a disease that happens in one day. And in fact, it's said to be a disease that starts from the womb and goes to the tomb. And the fatty streak, which is the early deposition of plaques in our arteries, start as early as adolescent, especially if we have adverse risk factors, especially if we don't take care of lifestyle and risk management right from early childhood. And this gradually builds on to become symptomatic where you develop this occlusive blockages, or unfortunately a plaque may rupture and you can have MI, or you can have a stroke, or you could have critical limb ischemia. So that is the manifest part of the cardiovascular disease. But there are years where it could be clinically silent, and where you also need to intervene to prevent these catastrophic events. On the right are, you know, what I do every day. These are images of a coronary angiogram. That's the left-sided images are those of a normal artery, that how it should look. It looks clean, no rough edges, while on the right side, the two images show blockages in our arteries. So are Indians susceptible to ischemic heart disease? Yes, there is a plethora of data on that. And each guideline, whether it be the European Society guideline or the American guidelines or the British, they clearly have being of South Asian descent as one of the risk modifiers, or what puts you at a higher risk for future cardiovascular disease. And we see this by a decade earlier onset of ischemic heart disease in Indians. We also see that premature mortality in Indians to cardiovascular disease is twice as common as that compared to the West. And if we look at migrants, we have a large diaspora of South Asians living all over the world, right? And if we look at data from those countries, it is very clear that the incidence of ischemic heart disease and cardiovascular disease among cohorts is very much higher in people of South Asian origin, whether this be studies from the UK, the New Zealand, Norway, and the point estimates may vary, but what is very clear that the incident CHD is at least 110% higher in South Asian men and at least 60% higher in South Asian men. What about the probability of having an MI? Again, these multiple studies have clearly shown that South Asian men have at least a 50% higher chance of having an MI, and women another 50% chance, at least higher of MI. Some studies have picked the individual numbers much higher, which I'm not even saying. So yes, South Asians are at a higher risk, and we need to be careful about it. So what are the risk factors? You know, as I said, ethnicity. You know, as one ages, one's probability of having ischemic heart disease is more. If you have a family history, it's more. These are non-modifiable risk factors. But we need not get overly upset if you have one of these non-modifiable risk factors, because there is ample that you can see on the left side of your screen, the modifiable risk factors, whether they be behavioral or whether they be biological, that can be modified to reduce your risk of ischemic heart disease. And that is the purpose of the talk. And I'll see what our targets should be, how these risk factors can be modified. The other risk factors are lipoprotein little a, homocysteine, inflammation, shift duties. You know, we now have seen our young individuals work in IT department, and they work across continents and therefore have altered circadian rhythms. That also leads to increased incidence of ischemic heart disease. And then there are, of course, other ignored contributors like the Parker hypothesis, where low birth weight at childhood, at birth, is also a contributor to future cardiovascular disease. And air pollution in our cities is again one of the leading causes contributing to precipitating acute cardiovascular events. And maybe now post-COVID, we know post-COVID is an inflammatory state, and that we don't have the data yet, but we know from series on influenza that whenever you have a lower LRTI, there is an increased chance of cardiovascular events. So these are some of the risk factors we know. Let's look at one of the most important risk factors, which is high blood pressure and how it works in causing cardiovascular disease. So it's very important to understand that the most of the cardiovascular risks work in a continuum. What does that mean? It means that every millimeter mercury that a person has higher blood pressure over 115 by 75, your risk for cardiovascular disease keeps increasing. And for every 20 millimeters by 10 millimeter increase in baseline cardiovascular disease, this is from cohort studies done over several years. For every 20 by 10 millimeter increase in blood pressure, your CVD mortality goes up by 2 times. So the higher the blood pressure you have, the more the chance of cardiovascular disease. And we clearly know from multiple trials that if you reduce the blood pressure just by mere systolic blood pressure by 10 millimeters and a diastolic blood pressure by 5 millimeters, you will reduce the chance of ischemic heart disease by 20%, stroke 35%, heart failure 40%, and mortality 13%. So just using very cheap generic drugs, if you're able to reduce the systolic blood pressure by 10 millimeters in 40 people, you reduce the chance of having a major cardiovascular event, CHD, stroke, heart failure, in one of those 40 people. So that's a hugely cost-effective strategy. So that's why we need to be treating blood pressure very aggressively, finding people with high blood pressure and treating them. In fact, newer study, and this is the landmark SPRINT trial, which showed that even more aggressive blood pressure lowering than the usual target of 140. If you target 120 in this trial, you've got further benefits in reduction in major cardiovascular events and 27% reduction in mortality. And based on this trial, in high-risk individuals, the clinical guidelines now ask us to target a blood pressure of 130/80 when we treat hypertensives, not 140/90 as was usual. But what's the scene in our background? And this is from a study done in National Capital Region, rural urban area. And unfortunately, as you can see, the control rates in our population is a dismal 15% in just about 10 to 15%, which speaks volumes about how little we are doing to reduce the ischemic burden in our societies. Also suggests that there is a lot of scope of doing things to reduce the CVD burden, which is a leading risk factor, a leading cause of death in India. So what should we do for hypertension management? There should be aggressive opportunistic screening, meaning whereby any patient beyond 25 years of age, at least, if he comes to you for any reason, he should be screened with a blood pressure. He may not be coming to a physician, cardiologist, any doctor who sees a patient. If he's a surgeon, he's an ENT person, he is a general medical officer, he should always screen for blood pressure in individual, whatever may be his presenting symptom. Because we know hypertension is a silent killer. It doesn't have manifest symptoms in large majority of people. We should target a blood pressure of 130/80 in high-risk individuals, and we'll see what we mean by high-risk individuals. Single pill combinations are the order of the day. What are these? These are pills which have 2 medicines in them. So anybody with starting systolic blood pressure consisting above 160, we should start with these single pill combinations, because it's been seen that most hypertensives will require 2 or more pills to control their blood pressure. So this helps improve compliance and improve control rates. And importantly, hypertension often coexists with other comorbidities, whether it be diabetes, obesity, dyslipidemia. So once you diagnose somebody as hypertensive, you should also screen them for other comorbidities, and we'll see why, because we need to reduce their global cardiovascular risk event. What about diabetes? We all know diabetes is a risk for chronic ischemic heart disease. If you see here from the classic Framingham study, you have at least 2 times higher risk in men, and even higher, about up to almost 4 times higher risk in women of having cardiovascular events if you have diabetes. But it's not always such a dismal prognosis for this people, for people with diabetes. And that's why I bring up this very important study from New England Journal of Medicine published in 2018 from the Swedish National Diabetes Register, where they showed that 5 cardiovascular risk factors in people with diabetes, that is HbA1c less than 7%, systolic diastolic blood pressure less than 140/90, absence of albuminuria, avoidance of complete abstinence from use of tobacco, and an LDL of less than 97. If you could maintain these 5 targets in people with diabetes, you could reduce their excess mortality, meaning thereby then their risk for cardiovascular events is just as much as that of a non-diabetic. There is no excess acute MI of patients if you're able to meet these 5 targets. So even people with diabetes who are otherwise considered high risk for cardiovascular event their risk can be mitigated by meeting just these 5 simple targets of cardiovascular events. But what if you don't? If you don't are on target with any of those 5 events, then the mortality is 5 times, especially if you're in younger people less than 55 years of age. And in young, if you don't meet any of those 5 targets, then your chance of MI is 8 times as compared to control. So there's a huge opportunity when you diagnose somebody as diabetes, that if you manage those 5 risk factors, you can mitigate their risk completely. So just to summarize, diabetes prescription should not be only about glycemic control. It should be about his global cardiovascular risk factor management, meaning thereby diabetes management, blood pressure management, management of lifestyle with no tobacco and other dietary advices that I'll talk about. What is new in diabetes in terms of reduction of cardiovascular risk? With the newer agents called the SGLT2 inhibitors and GLP-1 agonists, for the first time, along with metformin, have shown benefits beyond glycemic controls. So we should have a lower threshold to use these in these patients so that we can reduce their cardiovascular risk along with diabetes control. Coming to the lipids, again, as we talked about the continuous risk, it's again the same for lipids and mortality. So as your total cholesterol or your total cholesterol HDL ratio increases, proportionately your risk for having cardiovascular events and mortality increase. And the reduction, if you reduce by 1 millimole per liter, that is about 38 milligrams per deciliter, as we commonly know in India. If you reduce that much, you reduce the chance of a cardiovascular event by 25%, irrespective of the baseline risk of a patient. So even in low risk patient to very high risk patient with more than 30% chance of an event in future, you reduce the risk by 25%. Does that mean we start prescribing statins to all? Do we give statins in our tap waters? No. Why? Because here is the question which was put out to you on the opinion poll. You prescribe statins based on absolute risk of the individual. And let's try to understand this with this excellent graphic here. So if you treat 1,000 people with statins, and if they are low risk, right, less than 5% risk in the next 10 years or 5 years of major cardiovascular event, then you reduce 6 events, right? Only 6 events if you treat 1,000 people. But if you treat 1,000 people with 1 millimole reduction of their LDL cholesterol, then you reduce the events in 61 people. So what is this? This is basically saying it's much more cost effective. It's giving you much better bang for your buck, as the management people would say. So and so you are ready to take even slight risks over there. So your risk benefit ratio clearly outweighs as the risk for cardiovascular event in the individual is higher. So that's for statins is recommended in all patients who already have atherosclerotic cardiovascular disease and those who are at high risk for future events, which will we see how we calculate that. Lifestyle ischemic heart disease, there are chapters on this that can be written. So I'll be very brief, just one slide each. We all know that tobacco and cardiovascular disease have go hand in hand. The physician study from study from UK clearly showed that lifetime smokers lose 10 years of life if they use tobacco. And from Interheart, we know that as the number of cigarette smoked or BD smoked per day increases, your odds keep on going higher. And so no amount of alcohol is safe, no amount of tobacco is safe. What about odds of MI? So for smoked tobacco, whether it be cigarette or BD or other types of smoking, your risk for cardiovascular MI is odds ratio is 3 times. For chewed tobacco, it's 2 times as compared to people who don't chew tobacco. And if you do both, that is you smoke and chew, then your risk for having a future MI is 4 times. So as physicians, we will be failing in our duties if at every visit we do not emphasize on our patients for complete abstinence. We know the physical activity is protective, and each 1 MET increase in exercise capacity that an individual has confers a 12% improvement in survival. So that's what's called the survival of the fittest, maybe also coming from here. But it's also important that each level of physical activity, the more you sit, that if you sit more than 6 hours versus if you sit less than 3 hours, your odds of having adverse events increases by 30 to 90%. So maybe we should be I should be giving this talk standing up, and maybe you should be listening while you stand. So yeah, so the idea is to reduce not only increase your physical activity, but reduce your sitting times also. Diets, again, volumes can be said about the diet, but I'll be just very brief. The way diet affects cardiovascular disease in Indians is a little different from the West, where the excess CVD risk from diet is driven by a lot of fat in the food, a lot of processed food, and in that sense. While in India, we know that fats are not so high in our average diet. It's the excess of carbohydrates and low protein, low amount of greens in our diets and low amount of nuts, legumes that are present as compared to the ideal diet. And this may be what may be driving the cardiovascular disease epidemic. So just broad points, emphasize on the green on this graphic, plenty of fruits and vegetables. I know it's an expensive affair, but ideally 400 grams of fresh, locally available, whatever fresh and fruit, vegetables are available should be consumed. More of whole grains, more of plant proteins rather than animal proteins like legumes are beneficial. Low on salt and glycemic index that we all know. No trans fat in your diet, and as far as possible, possibly substitute saturated fats with PUFA and MUFA. And increasingly, the emphasis is not on the diet constituents, but the type of diet you take. So whether it be a Mediterranean diet or a DASH diet is what is recommended. Mediterranean diets are rich in whatever I said here. They're rich in whole grain food, they're rich in fresh fruits and vegetables, and they're low on salt and low on red meat. So coming to the most important part, when there is an individual or a patient sitting across your table or your family member at home, how do you assess his future cardiovascular risk? And how do you tell him what to do? I mean, as we realize, how do you assess his absolute risk for cardiovascular event so that you can start therapies early in this patient? So there are no perfect tools, and I can tell you these are all estimators that they are, but they are good estimators. The other disclaimer here is, unfortunately, none of these have been validated in an Indian cohort, right? These are done from cohorts which are abroad, but QRISK-3 is one of the risk calculators which we can use because they had a large number of South Asians in this in the cohort from which this risk calculator is derived. There were 400,000 South Asians in that cohort. So it's one of the good cohorts to use for Indians. It says that the risk for puts South Asian ancestry as a 1.3 times risk once you put South Asian ancestry as one of the components. Do these risk estimators do? They usually ask you for age, tobacco use, BMI, blood pressure, blood sugar, lipids, and family history. In fact, the Interheart's risk score, which has been again validated on an Indian cohort, is called a non-laboratory Interheart score. So for low resource settings, or for where you would not have the blood investigations, you can still do a risk score assessment through this Interheart risk score. But the QRIS 3 seems to be more feasible, more accurate one. And assessment of a CV risk should be done at all individuals, all adults, at least above 25 years of age. And then depending on their risk, whether they fall in the green, which is low risk, or the red, which is high risk, this can be repeated every 1 to 5 hours. So coming to our poll question, these are the two individuals. Mr. Singh, he has a very high blood pressure, as you can see, 176/84. Other risk factors are very much under control. While Mr. Kumar doesn't have any alarmingly high one risk factor, his blood pressure is mildly high, his BMI is a little high. He has an HbA1c, which is kind of okay, but he has a family history of cardiovascular disease. So who do you think will be higher risk? It's clearly the Mr. Kumar, the second individual, whose risk for cardiovascular events is 25% over next 10 years. While the first individual, Mr. Singh, just has a risk of 12.7% over the next 10 years. So the idea was to make you understand that's not one risk factor that determines the cardiovascular risk. It's the multiple, even mildly raised, but if there are multiple risk factors are raised, then your risk is much higher as compared to if only you have one risk factor which is raised in an individual. So it's very important to understand that concept of global cardiovascular risk assessment whenever we are seeing a patient. What about the risk modifiers? And there are several of them in the out there, have been tested in several studies. But if you look at an analysis of these, whether it be coronary artery calcium, coronary CIMT, the carotid intima medial thickness, the arterial stiffness, the equilibrical index, the HSCRP, they have been tested in several studies. But of this, probably only coronary artery calcification is the one which is the best discriminator and has a significant what we call NRI, that is net reclassification index. That is, it makes a substantial change in the classification of an individual from when he is in intermediate risk to it pushes them down to low risk or high risk. So there is limited value of doing this risk over the conventional risk calculator which I showed you. Maybe CAC is something that can be used in people who have intermediate risk and you would like to further risk stratify them as low risk or high risk, whether to start statin in them or not. So if you have a CAC of more than 100, you would start thinking of definitely starting statin in that individual. But if he's intermediate risk, CAC is 0, then you can wait on him before you start the statin. What about other cardiovascular tests? And it's very fashionable nowadays to have the executive checks. Even central government offices, we know during their annual assessment, they have to undergo a medical check, which includes a lot of TMTs. But is it worth doing it? Does it add value or does it create disease? So let's look at an average individual, 45-year-old man, has no risk factors. He has a good exercise capacity. What would happen if you subject him to ECG or TMT? His probability of having CAD at best, is 5%. And we know the test sensitivity and specificity are in the range of 68 to 70 and 77% respectively for an exercise ECG. So if you subject 100,000 such individuals to an exercise ECG, what do you get? You get true positive in 34%, 34 individuals out of 1,000, but 219 people, if you take this low risk individual, would be falsely positive. So they would undergo further tests, they would have psychological issues with getting a test positive, and literally several downstream investigations, which are, and they are often off or over-treated. So, it's important to look, of course, if this individual has a 30% risk of having CAD, then you could subject him to this test, or he had intermediate probability of having a CAD, then you could subject him to this test, and there the ratios are much better. So it's important to understand the concept, mathematical concept of Bayesian theorem when you start ordering tests. So you do not do this indiscriminately. What about advanced imaging? And there are excellent tools now, whether it's the nuclear medicine, stress, myocardial perfusion imaging, or the CT angiography that gives you details of coronary anatomy. They are excellent tools when used correctly, but should we use them for all? And whenever we've seen in recent times also, whenever there is some media personality or some famous personality has an unfortunate cardiovascular event, there is a clamor to do more of these tests. But do they really add value? And these are two randomized controlled trials in people with diabetes mellitus. And what did it show? That if you subjected all of them randomly, one arm to usual good medical care, doing all the things that we discussed, and the second arm, when you did all that and subjected them to a nuclear test in diet study, or in factor 64 trial where you subjected all of them to CT angiogram, what did you achieve? You did not achieve any clinical benefit. So there is no role of doing these tests indiscriminately in all. It has no additive value over usual good clinical care, which is based on guidelines. So no indiscriminate use of these tests. Just quickly winding up with aspirin, which is remains controversial, but now it is very clear that you should use aspirin for all individuals who have cardiovascular disease, who have established cardiovascular disease. So for example, if he's had an MI, a stent, he's had CABG, then you need to give him aspirin for life. For primary prevention, recent trials have clearly shown that there is very limited benefit. And if there is any benefit, that is negated by the increased bleeding in these individuals, and the events, number needed to treat and number needed to harm, are nearly equal. So it should not be used in primary prevention, especially because now statins are widely used and they have limited the use of aspirin. Maybe in some very high risk individuals with maybe very high coronary artery calcium score, it may be used, but it should not be used as a routine in people with for primary prevention. Just quickly talking a slide on STEMI management, and this is what really kills in ischemic heart disease, and every physician should be aware of its management. And the key management strategy is time. Time is muscle, as they say. And what have you to do? You have to be very sensitive to the time. You have to have a low index of suspicion for people who are having, chest discomfort. For early detection, if the symptom is lasting more than half an hour, you should quickly order an ECG, because that's all that will distinguish whether it was just an episode of acid peptic disorder or it is a frank MI. Clinically, it's very hard to tell one between the other. You must, as what can be called a first aid, initiate therapy with aspirin, which reduces the cardiovascular mortality in the patient with ST elevation MI by 23%, almost equal to that of thrombolytic therapy. You add clopidogrel, which gives you further 20% reduction in mortality, and you add high dose atorvastatin. These are first aids in MI management, and patients should be initiated on them whenever you're suspecting MI. And most importantly, as you can see, again, this was a poll question, that you need to reduce the time. If you reduce the time by, from more than 6 hours to less than 1 hour, in reperfusing these patients, either with primary PCI or with thrombolytic therapy, you reduce the mortality by 50%. So you need expedited definitive therapy, which could be a primary PCI, it could be thrombolytic, or it could be an in-between strategy called the pharmaco-invasive strategy, where you thrombolize in the absence of a cath lab immediately. That's a good strategy in India. And then you shift them for catheterization within 24 hours. So talking about secondary prevention, we see, once you have an established cardiovascular disease, the chances of recurrent event are very high. But you can reduce that by 80 to 90% if you adhere to these lifestyle measures that we discussed. If you adhere to antiplatelet therapy, if you give high-dose statin and target an LDL less than 100, preferably less than 70 in high-risk people, a BP less than 130/80 in high-risk cases, and a HbA1c less than 7%. I know it's difficult to have people on years of therapy. These are lifetime therapies that are needed in most individuals once they have cardiovascular event, and they often fall off after the initial couple of years because it's, preventive therapies doesn't have such great compliance, but you need to insist on that to prevent recurrent event in these high-risk people. And here comes the role of polypill. In India, we have several types of polypills, and we could customize these polypills for them so that the pill burden is lower and we improve compliance on a long-term basis in secondary prevention. So coming to the end towards my talk, so what can we do to reduce the societal CVD burden? Lifestyle interventions have to be widely used, which is tobacco control, healthy diet, physical activity, and this should be used for all adults. And this will have maximum impact because you're going to impact lots of number of people. You need risk factor control, which we talked about. You need prompt acute coronary syndrome management because it can lead to sudden deaths. You need to ensure secondary prevention, and wherever needed, we need revascularization with angioplasties and bypass surgeries. And this has shown that this strategy can reduce CHD mortality by 50%. And we have learnings from the West where all these countries were able to reduce their CHD or ischemic heart disease mortality by 50% by doing all that I said. And you'll be surprised that 60% of the benefits are coming from population level risk factor reduction in use of tobacco, lowering cholesterol by better diets and lifestyle, lowering the population BP level by lowering sugar, salt intake in the diets. So that contributes almost 2/3 of the benefits. Rest 1/3 come from definitive therapies, whether it be treating MI, as I said, having widespread secondary prevention in and or heart failure management, and a small benefit comes from CABG and PTCA in the patients who require this. So my take-home message for today's talk will be, South Asians, yes, are vulnerable to ischemic heart disease, but there is a lot we can do to reduce their risk. We need to target multiple cardiovascular risk factors which work as a continuous and constant risk over a wide range without any thresholds. We need to assess individuals for their cardiovascular risk and target therapy accordingly. We need expedited management of acute events. We need increased uptake of secondary prevention strategies, which can save many lives. And community lifestyle improvements can markedly lower the CVD burden. Thank you for your patient hearing.
Thank you, Dr. Ambush. Thank you so much. It was a very crisp and very insightful session. Thank you for that. I am right now having trouble downloading the questions which we are receiving from our candidates. But in the meantime, all the participants, when they registered, they have given us a couple of questions. So we will start with those questions. And I can see there are a lot of questions which are coming up, especially on the, certain MI, especially in the young population. So there are questions like what are the causes and what is the incidence of certain cardiac death, especially in young population. And recent past, we have seen a couple of examples, even the celebrities and everywhere. So if we can start from there, and I'll try to get more questions from other groups.
So in young, one of the clearly the biggest risk factor is tobacco use. And we increasingly see that, people who are presenting with MI in their 30s, most of them have tobacco use in the background, and it is the single largest risk factor for that. Then the other risk factors are the stresses, the change in circadian rhythm. Increasingly, people work across continents, so the change in the shifts of work, the stresses of modern life, drug abuse, unfortunately, is on the rise, and some of these drugs are very potent coronary spasm, create spasm. So that could be one of these risk factors in young. But as I said, South Asians are prone to cardiovascular disease, and it happens a decade earlier. So all these lifestyle interventions, cardiovascular risk assessment at a young age are important to prevent that future event.
Sure, I think we are genetically, we are engineered in that way that we are more prone for these diseases. Coming to the next question. So role of dual antiplatelets. What is the dose? What is the duration? And if we can choose ticagrelor, and when we can use prasugrel.
Okay. Yeah, so I got that question. Yep. So most of the time, large majority, you need to give single antiplatelets. But in individuals who had a recent MI or recent stent, there is the role for dual antiplatelets, and you can give aspirin is definitely one of those antiplatelets. The second antiplatelet could be clopidogrel, ticagrelor, or prasugrel. While ticagrelor and prasugrel are more potent, and so they reduce cardiovascular events more than clopidogrel, but they come with a baggage of higher bleeding rates. So you need to weigh those risks and benefits in an individual patient. So if it's an elderly patient you just had an MI, you would prefer clopidogrel. While if it's a younger patient who's received multiple stents, you would definitely prefer prasugrel. So you need to individualize that. But yes, post-MI, 1 year is when we recommend dual antiplatelets. And if he's had no event within that 1 year, we switch to lower our antiplatelet potency to use a single antiplatelet, that is aspirin.
Dr. Ambuj, what is the dose recommendation for aspirin or clopidogrel?
Yeah, so to aspirin, most of the studies have shown that a low dose aspirin is as good as giving high dose. So anything between 75 mg would be suffice. Maybe if you're using somebody with a high body weight, you can try 150 mg, but for most of the average weight, 75 mg would be suffice. But for prasugrel, it's 10 mg once a day, and for ticagrelor, it's 90 mg twice a day.
Clopidogrel?
It's again 75 mg.
Oh, it's okay, fine. Coming to our next question, whether the COVID pandemic has increased or is likely to increase the risk of IHD, and if yes, is the demographic profile an important factor for it?
Yeah, that's an excellent question, and I just briefly touched on one of the CVD risk factors. So we don't have data so far whether it has increased MI or not, but that data is likely to come up from large cohorts. But we have learnings from the past where you've had flu episodes, and they have clearly in individuals within the cohort who had flu versus who didn't have flu, the risk for MI increases by 2 to 3 times, and risk for heart failure increases even more, 4 to 5 times in the people who develop that flu. So there is no reason why COVID should behave any differently, because we know COVID leads to inflammation, and inflammation is a trigger for cardiovascular events. And that's why you give flu shots in people who are high risk for CVD to prevent these flu episodes and to prevent recurrent cardiovascular events in them. So there is a very high likelihood that the same may have it COVID. But what is important is what you could do. So it's very important that in the post-COVID stage, when you're managing such patients, you ensure that you do what you can do. Yeah, you make sure that you're not managing their post-COVID, if they have lung issues or if they have fatigue, but you make sure that these patients are also controlled very tightly for their cardiovascular risk assessment. You make sure that blood pressures are under control, your lipids are on targets, your diabetes is well controlled. So that is what you can do to mitigate these risks. So it's very important to stress on things that you can do on these patients. So make sure that these patients are taking their therapies, are taking their blood pressure, diabetes medicine, and secondary prevention medicines, so that we reduce the chance of a recurrent event in these patients.
Thank you. We have got a question from, Dr. Mohan Kumar, and he has asked, what is the prevalence of silent IHD? Also, there's a question where specifically the doctor has asked about the incidence of IHD among pregnant women. So is there any data which is available on the incidence and prevalence in young population as well as in pregnant women?
So broadly, in the young, the prevalence of ischemic heart disease would be in the tune of 5%. Silent MIs are more common in people with diabetes, people with chronic kidney disease, or elderly, or women present with atypical symptoms, typically with ischemic heart disease. They may present less with pain, more with breathlessness, nausea, those kind of symptoms. So in women, you need to be careful about the alternate presentations of ischemic heart disease. In pregnancy, I don't think in our countries there is any high incident of ischemic heart disease. But yes, pregnancy induced. So, answering a little different question, but if you have pregnancy-induced hypertension, or if you have gestational diabetes during pregnancy, these are red flags. Remember, this may resolve post-pregnancy, but these are the people to watch out for because there may be in a future diabetes
high likelihood
in them. So, and high CVD risk factors. So these women need to be more closely monitored than others.
Sure. So we have a question from Dr. Madhikari from Karnataka Medical Council. So he has asked, how do we go about the lipid management in patients with multiple comorbidities? Is it the better approach would be lesser the better and aim for as low as possible or go according to the guidelines and the targets which are set?
Yeah, so it really depends on what you're looking at, primary or secondary prevention. But if you have multiple cardiovascular risk factors, so then you would probably be in the high risk category if you already do not have cardiovascular disease. So yes, in them, intensive lowering of lipid is recommended. And, in the highest risk is less than 70 milligram per deciliter is what our targets are. But at least achieving less than 100 mg is our target in high-risk individuals. So we obviously need to have aggressive lipid loading in people with multiple comorbidities, cardiovascular comorbidities, as far as possible.
So we have a question from Dr. Ashok Deorari, and he has asked, how can we control LDL cholesterol in diet recommendation in addition to the statins?
Yeah, that's an excellent question. But we increasingly know that the impact of diet on the LDL cholesterol is not very high. And a lot of it is determined by the genetic determinant rather than diet. Yes, reducing saturated fats in diet, reducing cholesterol per se in the diet can bring that down by 15 to 20%. But that's all that it will do. Physical activity will add 10-15%. These impact triglycerides much more than they impact LDL cholesterol. So unfortunately, LDL cholesterol has a much smaller correlation with your diet, but more with your genetic makeup. But yes, that doesn't mean you don't be on the right healthy diet. Because it will have other benefits in terms of cardiovascular risk mitigation. So diet will reduce your LDL by about 15-20%, but that's it. Beyond that, you need the help of statins.
Dr. Ambuj, India as a country, we are very heavily dependent on our carbs. that takes care of the major portion of our diet. So how these carbohydrates, you mentioned about, we should lower the carbohydrates and increase protein intake. What can be substituted, if we have to substitute carbohydrates? What else can be added to the diet?
So in general, if you see, you're very right, and I pointed it out, our diets are different from the Western diets in terms of contributing to cardiovascular disease. And we have very high carbs in our diets. We have very low legumes, for example, proteins in our diets. So what you could do is, if for as far as carbs are concerned, go for whole grains. The good old times when we had a lot of millets, we had
bajra,
those things which are really coming back in fashion, thankfully, a fad food now. But those are the kind of foods that we need to have. Reduce flour, especially very refined flour in your diet. But if you're using rice, go for red rice, brown rice. Whole grains is what you should consume for carbohydrates. Increase legumes in your diets as far as possible. If you're a non-vegetarian, meats are fine. Fish is good, actually cardioprotective. Chicken is fine. Whatever
red meat,
possible red meat is to be avoided. And we also need to very much emphasize on greens. We are vegetarians, so to say, but our consumption of fruits and vegetables are extremely low if you see on a national level. I know it's an expensive thing to have lots of greens and vegetables, but whatever is local, seasonally available, you must do that. And very importantly, you should not cook your fruits, greens to death. You need to have them as fresh as possible. We, unfortunately, whatever greens we do, we kind of fry and
oh my God, we kill it. Yeah. Okay, so now I can get some questions reflecting. So Dr. Chetan Kumar, he has asked, how do we manage steroid-induced hypertension in SLE patients? Okay, and do they have same risk factor for CVD?
Yes, so obviously hypertension will have similar risk factor, but having SLE per se is, again, as I said, an inflammatory condition and will increase your cardiovascular risk. And if you look at the QRIS-3, it actually takes into account autoimmune diseases as a cause for cardiovascular disease. So if you have hypertension and SLE, that puts you at a higher risk for CVD event. But the management would be kind of similar to hypertension. You could use calcium channel blockers in them. It's a good drug to use, and you could even use RAS inhibitors in these patients unless they have renal involvement. So you need to individualize the therapy, but you would like to target a blood pressure for about 130/80 in these patients.
Okay. So we have next question from Dr. Sumzida Afreen, and she's asking, what are the indication and contraindication for stress perfusion imaging?
Yeah, so I did briefly speak about it. It should not be indiscriminately used. So if you have intermediate risk for CVD, and that's again determined by kind of symptoms you have. So a middle-aged patient presenting with some exertional symptoms where you are not sure whether it's CAD or not, you should subject them to a nuclear perfusion imaging. If you have an individual who is an elderly but having atypical angina, as we say, it may not be always exertional, but he has some chest pain, you could subject them to a stress test to know whether it's CAD or not. What about contraindications? So if somebody has very obvious angina on minimal walking, he develops this chest pain, a crushing pain, you should not put them on a nuclear scan. You should not exercise them, but rather straight away do a coronary angiogram in those cases, because stress may precipitate an MI. So you would not like to do it in those cases.
Dr. Ambuj, next question from Dr. Shashikala, Karnataka, Bangalore. And the question is how to assess cardiovascular risk in single vessel disease patients treated with stent, and when CABG is indicated.
So most of the single vessels, we would not recommend CABG. They would, be managed with a stent unless it is in the left main artery where you're not very confident about the stent. So I mean that's a very individual treatment, and you'll have to see the anatomy of that person, the coronary anatomy, and decide. But generally, once you treat these patients, a single vessel disease with a stent and good secondary prevention strategies, meeting all the targets that we discussed, generally the risk for cardiovascular events can be substantially reduced to about 1% per year in such individuals. So manage them with a stent and with good secondary prevention, and make sure that they're compliant over a long term to reduce their future cardiovascular events.
Dr. Ambuj, is it so that triple vessel disease patients, CABG is a better option compared to stent?
So broadly, yes, especially if it is triple vessel disease with diabetes. If it is triple vessel disease involving the proximal arteries, it is better to go with CABG. There was a very landmark trial called the FAME-3 trial, which just recently published, which clearly showed that CABG is better in triple vessel disease, especially with complex anatomy, especially if the individual has diabetes. It is always better to go towards CABG than triple vessel stenting. But some anatomies where they have a very discrete lesion in all three arteries, and you can do a good result with the stent, you may go that route, which is a less invasive procedure. So again, needs to be individualized, but broadly, yes, triple vessel disease would be more towards CABG than stent.
So next question from Maldives, and want to know, in which situation should fibrates be used instead of statins?
So I would say always statins have to come first, and fibrates have very limited role over and above statin. And there was a very big trial called the Accord lipid trial. Exactly, they did this in diabetics. They introduced fibrates over and above optimal statins, and it led to no benefit. But yes, you can make an argument that South Asians have higher triglycerides and fibrates may have a low role. So what I would suggest, you give them the maximum tolerated high dose statin. And if their triglycerides are still above 150, you may think of introducing fibrates, hoping that it'll help, although most of the trials have shown limited benefit of fibrates over maximal doses of statin, but that may be one area where you could use it.
Ambuj, last two, I have a lot of questions, but we'll just take last two questions. So next question is from Telangana, Dr. Shantam, and his question is, role of serum homocysteine as a diagnostic marker.
So serum homocysteine has shown correlations with coronary artery disease, and once you have a high levels, there is a susceptibility because of a thrombogenic milieu that is created of having ischemic heart disease. Unfortunately, trials where you've treated with folic acid, for example, to lower homocysteine have not shown that benefit. So it is a risk for cardiovascular disease, and you could do consider reducing therapies in these people. So it is a risk marker for cardiovascular disease, but treating homocysteine in the trials have not shown benefits.
Okay. And from Chennai, Dr. Jinesh is asking, what about dapagliflozin in cardiac patients? So is it safe to be used in comorbid condition?
I touched upon that. It is definitely a drug which should be given in all patients with cardiovascular disease. It has clearly shown reduction in cardiovascular mortality, and more importantly, in heart failure onsets in these patients with diabetes. So people with cardiovascular disease, if they are diabetics, SGLT2 inhibitors should be definitely used unless there are obvious contraindications like infection or a past UTI, because these drugs definitely increase the chance of genitourinary tract infections. Whenever you prescribe these SGLT2 inhibitors, you need to educate the patient about good genital hygiene, very importantly, because there can be catastrophic side effects, but they are extremely low if you use them with proper medical patient education.
So I'd like to conclude this question and answer session with the last question. In this era of vaccine for infectious diseases, can we anticipate a vaccine in future for IHD? Will it be benefit to the people, general public?
I mean, that's a very futuristic question. There's a lot of work being done in the area of antibodies to LDL, and LDL immunogenicity is being studied. These are unfortunately still in the bench and not being translated into clinical trials. But yes, we know the important role of inflammation, and we know that if this comes through, it will be immensely beneficial in reducing the #1 killer in the world. But it is still in the early phases, and people are working on it. And hopefully it will be there in the future. But my idea today, there are several things which are in your grasp today. There are several low-hanging fruits that can, so to say, that can be tackled right now, whether it be very simple lifestyle measurements, BP, sugar, cholesterol management, which can substantially reduce the CVD of the individual and of the society. And this is something which we need to, as responsible citizens and physicians, should embark on to reduce the CVD burden in our country.
Well said, and I think very importantly, you have summarized at the end, these are some of the very important things which need to be handled before we come to bigger modalities. Thank you so much. On behalf of BMJ, I would like to thank you. And right now we have 400 plus participants who are online. On behalf of them also, I'd like to thank you for the wonderful session and for answering so many questions. Right now, I was having problem with the internet and I was not able to get as many questions. I'm sure there are more questions, but right now, because the time is such, we've already exceeded by 10 minutes. So we'd like to thank you from the bottom of our hearts and to all the participants for giving us your time. I always say this is the investment. You have time investment, you have financial investment, and your focus. So thank you for investing your time in this clinical update series. And we would like to announce for our next update, which is scheduled for 24th February. Sheetal, can I have the slide deck, please? Yes. So thank you for your time today. And 24th February, we have mentioned that if you'll follow us, our next clinical update is scheduled for 24th, and our subject expert is Dr. Prince Jain, Professor and Head of the Department, Interventional Pulmonology and Respiratory Medicine at Naruvi Hospital, Vellore. We'll be happy to hear out. We have 12 series. We have already done with the first one today, but if in case you want to hear any specific topic, any special area which is of interest, we would appreciate if you can share your suggestions on the topic update, and please use the chat box right now to share your feedback on the topics. If anything is there, we have scheduled a couple of next webinars, keeping those in mind, but we'll be happy to have your suggestions. We'll plan our next series accordingly. So with this, we bring this to the close. Thank you so much for attending, and please watch out for this space. Follow us on LinkedIn and Facebook pages. Our ID is @BMJ India. You will get more updates on this. Also, once now we are concluding the webinar, so you will be able to download the certificate and it would be reflected on your screen. That's it from our side, and see you next month, Thursday, 3 to 4, 24th February. Thank you, sir. Thank you for your time. Thanks.